Reflux is not uncommon in the community. Up to 20% of the UK and the Western population have symptoms of reflux. So it's not unusual to have symptoms of reflux. When we say reflux, primarily we're describing heartburn, regurgitation, perhaps some chest discomfort. Patients can also describe symptoms of reflux up top, such as a burning sensation in the throat or sensation of food or fluid rising up to the throat. Patients can also present with cough, but the primary symptom of reflux is heartburn and regurgitation. Commonly, patients who have these conditions see their doctor and they're provided with treatment such as with antacids, such as Gaviscon, or with medication that stops acid from forming in the stomach, such as omeprazole and lansoprazole. But where patients have ongoing symptoms and they would like to be investigated further, and in particular if they're being considered for an anti-reflux procedure, then we tend to need to assess the frequency of reflux and the volume of reflux and what reflux events are leading to symptoms. So a reflux symptom association. We investigate this in one of two ways generally. Either we perform a catheter-based pH monitoring, which is the standard. This is the catheter-based pH study. A very flimsy, thin tube is placed from the nose down to the stomach. It has sensors across it and a sensor at the bottom. And that measures acid reflux in the bottom of the esophagus. A recorder, such as this, is carried along with you for 24 hours, and it measures how much reflux takes place. And also, you have buttons here that you can press whenever you have a symptom. If you have a symptom that occurs, then you press the button, and each symptom is assigned a button. And also when you lie flat or sit up, or when you're about to start eating and when you stop eating, that way we can define exactly when the reflux is taking place. The useful thing about this catheter is that it also has sensors called impedance. So that measures not only acid reflux in the bottom of the esophagus, it also measures how much reflux comes up to the top of the esophagus and whether that reflux is liquid, gas, or mixed. Because it's important, especially in patients who have symptoms up top, how much of that reflux is taking place, not just how much acid reflux is taking place at the bottom. This is a 24-hour test. Most patients tolerate it well and there are no issues. Very rarely do patients not tolerate it. But in advance of doing this test, we need to perform a high-resolution manometry because sometimes patients who have symptoms of reflux, in fact, also have motility disorders which we need to identify. And the manometry also provides us with information with regards to where to place the pH sensor, because this pH sensor has to be placed in a particular spot in the bottom of the esophagus, and the manometry provides us with that information. If patients don't tolerate this procedure, there is another option. The other option is called wireless pH monitoring. This is performed using endoscopy. A capsule, which is, you can see here, is placed with the aid of a wire down the esophagus and into a position in the lower esophageal, at the bottom of the esophagus. This is measured on endoscopy, so you don't need manometry. And again, you carry a recorder for the next 4 days. The wire is taken out and the capsule remains in place, and usually the capsule drops off on its own after a few days. This measures how much acid reflux takes place at the bottom of the esophagus. And there is no wire that comes out of the nose, so patients say that they feel more comfortable. It also measures for a longer period of time in case you have symptoms or reflux events that occur one day, not the other, so you can capture it. So this is a very useful test, especially when the catheter test is not available. However, one is not better than the other. Each of those provides a different set of tests. So for example, if you have problems that are up top, or if you have a belching problem, or if you have a problem of regurgitation whereby food is rising to the top, and you're trying to determine how much is taking place at the top, the catheter-based study is important because it measures everything up to the top, and it measures acid as well as non-acid reflux. While if you are interested just at what's happening at the bottom of the esophagus, and you're just interested in acid, and when your symptoms come on and off, and you want to measure for many days, then it is this capsule that is important. And that way you can have the procedure done in endoscopy under sedation, then you go home for 4 days. Each of these tests provide different information, but ultimately, if one doesn't tolerate the catheter test, the wireless test is the next best option. So patients sometimes don't tolerate insertion of the tube, so whereby the tube is placed from the nose down to the stomach. That sensation of something going to the back of the throat, they don't like, especially considering that in advance of the pH catheter insertion, you need to have the high-resolution manometry study first. The high-resolution manometry is a slightly thicker tube, still very flimsy. Most people, more than 90% of patients, are able to tolerate its insertion, and there's no issues at all. But there are some patients who just can't or don't like the idea. We have the option of potentially putting the tube down when you're sleepy in endoscopy, but primarily the procedure needs to be done while awake. And if patients don't tolerate it and they don't like the idea of having it done in the first place, then the wireless test is available. But let me reassure you, although it sounds scary, I've had this done on myself 3 times, 4 times in fact, and it wasn't a problem. And the majority of our patients, more than 90%, are very well and comfortable. We can have a numbing agent in the nose so that you don't feel it going down so much. And then as soon as it's down, you're fine and it's comfortable. And patients are able to go through their daily activities without a problem. After the test, you carry the recorder, which is the appropriate recorder for whichever test you're having done, with you, and it needs to remain close to you so that the recorder measures what's happening. If it's a wireless test, you need to make sure that it's close. If it's the wired test, well, you can't take it too far away from you because it's attached to you. You'll have a diary and you have buttons. You have to press the button every time you have a symptom. You have to press the button whenever you have a meal, and when you start and when you stop it. You also have to press the button when you lie down and you sit up. This is the same for both of them. You need to go about your normal daily activities. You should not sit in front of the TV huddled up waiting for the test to be over, because we need to reproduce your normal reflux-provoking activities. But what's important is that you need to have stopped your medication 1 week in advance, because we need to make sure that we're testing what your esophagus is like without any treatment. If you have the test done with treatment, then all we're doing is testing how good the treatment is, not whether or not you have reflux underlying. So you will often have a information leaflet that describes you or asks you to stop your medication, such as omeprazole or lansoprazole, 1 week before. You can resume your medication as soon as the test is over. Once the test is over, for the 24-hour pH study, you can either remove it yourself and detach it from the recorder, or you come in and we remove it for you. The capsule itself, if you're having that done, that drops off on its own, and in the next 3, 4, 5, 6 days, it'll pass through the stools. And the recorder you need to return, and we download the information as well as a diary card which we ask you to fill regarding everything that's happening, whatever you're eating and drinking, whatever symptoms are occurring, so we can cross-check what's happening on the recorder that you've pressed as well as the diary. And then we produce a clinical report that describes what's happening. The report that is produced at the end is sent to your doctor, and the doctor will need to look at the report and marry that information with your clinical information. Often this also is associated with a high-resolution manometry report, especially if it's a catheter-based study, and that all needs to be put together as one and correlated with the symptoms. Treatment of reflux can be either with medication, such as omeprazole, lansoprazole, or similar, that stops acid from forming in the stomach, and such that when you do reflux, it's non-acid and less uncomfortable. You can have an antacid, which can be taken alongside the medication, the acid-reducing medication, or in and of itself, such as Gaviscon, and this forms a layer on top of your food and reduces the amount of reflux that takes place. And then we have interventions. Interventions can be either in the form of a fundoplication done by surgeons, whereby the surgeon takes the top of the stomach and he wraps it around itself, either full way, which is a 360 Nissen fundoplication, or halfway. And these discussions you can have with the surgeon to determine which is the best option. There's other options such as a Lynx procedure, whereby a titanium ring can be placed at the bottom of the valve such that it opens and closes according to when you're eating and reduces reflux. And this has its benefits and its risks. Again, a surgeon needs to go through the benefits and risks of having this procedure undertaken. Again, it's performed under surgery, under general anesthetic. There are other treatments also. So, for example, if you have a hypersensitivity in the bottom of the esophagus, there are treatments such as stretta, which whereby energy is pushed through into the skin of the esophagus at the bottom, and that can reduce the sensation that you're experiencing. And the most common treatment that is being undertaken by the gastroenterologist now with regards to reflux therapy is transoral incisionless fundoplication, also known as TIF, whereby we can actually perform a fundoplication. We can actually recreate the valve, but done under endoscopy with a device that can imitate the wrap that the surgeon does, but with the camera, and recreate the valve with plastic fasteners that bring the valve down and produce a wrap. And that works very well as well, and can be done in endoscopy under general anesthetic with just one overnight stay. All of these options are available, and all you need to do is have a chat with your doctor after having the tests undertaken to determine what treatment options would be most appropriate for you. May they be with medicines or interventions, or with behavioral modification therapy if you do have a condition such as supragastric belching, rumination, aerophagia. In that context, you need behavioral modification therapy and not an intervention.